Okay. So as you can see, the title of my presentation will be focused on the preventive treatment of anastomotic biliary restrictors in pediatric patients who receive a liver transplant. And I added at the beginning a nice question, where we are. That means I'm going to speak about the current treatment and where we'd like to be. That means that we are not very satisfied with the current results, and we are moving forward in order to state a new protocol that we would like to include in a new algorithm for the treatment of decisions. Okay, so as you know, liver transplantation is a standard of care not only for pediatric patients, but all patients with end-stage liver disease and also unresectable hepatic tumors. First of all, I suppose you have 20 minutes for my presentation, but I realize that I have only 15, so I'm going to be a little quickly. As you know, survival rates are very high, and it's about 90% after the first year, and more than 80% at 5 years follow-up. So what about pediatric liver transplantation? As you know, this kind of transplantation can be performed with a whole liver implant, or particularly in children, the split liver. The split liver includes the two lateral segments of the left liver, and sometimes also the 7/4 is included in this split liver. The main advantages of this kind of implants is that these small livers accommodates very well with the size and needs of these pediatric patients, and the use of these kind of implants avoid the use of some implants that are prepared for or available for adult patients. Okay, so usually with the whole liver, the surgery requires 5 anastomosis. These anastomosis are 2 related to the inferior vena cava, and 1 for the hepatic artery, 1 for the portal vein, and 1 for the biliary ducts. But particularly, so this figure represents very well what happened with these split livers. So as you can see, the anatomy changed a little bit, but you also have the portal vein, the artery anastomosis, and the biliary anastomosis. This biliary anastomosis is where we are going to focus this presentation. So in our hospital, the liver transplantation program working in the National Hospital of Paediatric in Buenos Aires. This program started in 1992. Up to today, the liver transplantation program, the department, has transplanted more than 650 patients, and this is a mean of more or less 30 transplantations per year. So we also need to keep in mind the clinical condition of our patients. It's very important to keep this in mind in order to decide what kind of procedures we are going to perform in face of each complication. So, as you know, survival after pediatric liver transplant has significantly improved in recent decades, and this is strictly related to advances not only in with surgical techniques, also with immunosuppressive therapy and perioperative care. And also, as I said, with perioperative care, but we know that this is also related to the advances that radiology, diagnostic and therapeutic radiology offer to this population. It's working very well. And these advances in radiology are related also to the early detection and treatment of these post-transplantation complications that lead to improved graft and patient survival, and in many cases, as you know, I'm sure that you agree with me, avoiding the need of surgical revision or transplantation in many cases, not always, but in many cases. So, biliary complications, the main issue of this presentation, occurring in approximately 20 or up to 40% of patients, according to the accompanying literature. And these complications include strictures, leakage, stones, and even bilomas. And as I mentioned before, I'm going to focus this presentation on the biliary strictures. That is, I believe, the most difficult complication that we need to face. So this is a nice case of a liver patient. You can see here, this is a problem. It's very irregular here at the anastomosis, but the problem here is not a stricture, is this biliary leakage. And you can see here, this leakage is going far away, and you can see here, I'm injecting with a syringe a little bit of contrast, and I'm joining this through this subcutaneous channel the way of this fistula. So this patient was treated. You can see here, this is a percutaneous drainage, and we kept this drainage in place for 40 days, and this is the final cholangiogram 40 days after after this treatment, and this patient went very well. So, but I said, this is not the main issue or the main problem that I'm going to discuss in this presentation. But you will see why I'm showing you this patient. So, as I said before, anastomotic biliary strictures are a common problem in this population, and the reported incidence is up to 35, even 40%. And it's mainly related to scar tissue and retraction at the suture site. I'm a very nice guy, I'm very kind also, so I'm not going to say that in sometimes this is related to technical issues. I'm not going to say that because surgeons are very close friends. So, it's a joke, of course. So untreated biliary strictures are associated with high morbidity and mortality. But I would like to add here, not only untreated, only delayed treated strictures may lead to increased morbidity and also many times to s.r.o. So we need to keep also in mind that most of these pediatric patients has a hepaticojejunostomy with IDEA reconstruction. So many times endoscopy is really feasible. So that means that the cutaneous interventions are usually the only treatment approach for these patients. So this is the patient that I showed you before. So 1 year and a half later, you can see this tight stenosis at the anastomotic biliary anastomosis. So we dilated with a conventional peripheral balloon, and the patient left the room with the cutaneous drainage. This is the current treatment. We are performing this kind of procedure, treating these lesions, and everywhere in the world, these kind of complications are treated like that. So we kept this drainage for 3 weeks, and after 3 weeks we perform a cholangiogram, and we see if it's need to dilate one time or to retrieve the catheter. So it's accepted that the test techniques for biliary strictures are safe and effective, and success rates are varies very widely in the literature, but more or less all papers conclude that more or less 34% after a single course of therapy reported as a success rate, and also 60% after repeated treatments. But if you see in detail, this 60% after repeated treatment means that sometimes some patients can be treated 10, 12, or 15 times during this the whole period. And even though long-term stenosis and the recurrence of this stenosis are reported more than 3%, particularly in this period with a mean follow-up of more than 2 years. So patency rates at 6 months are 80%, however in long-term follow-up is almost 50%, and we also accepted that the use of percutaneous deployment of metallic stents is not a solution, because the long-term follow-up of these patients show very poor results, and is not indicated in benign stenosis. Even though I'm going to show you one patient where we needed, or we decided to use a metallic stent. This patient had this metallic stenosis and anastomosis. He received 3 sessions of cholangiography, that means 3 sessions of balloon dilation. We kept the tube in place. So this was the result after 3 sessions of dilation, surgical reconstruction, another 3 sessions of balloon dilation. So we discussed with the surgeons and we decided to deploy a metallic stent. And you can see here the result is quite well, but we had all the problems that are reported with kind of prosthesis. That means early occlusion and the need of new procedures in order to recanalize this prosthesis. So metallic stents are not the solution for this patient. No, this is the results of this kind of prosthesis. But we have, as I mentioned before, sometimes we have very nice results, as you can see here. Stenosis and anastomosis, balloon dilation, and this is the final control. This patient went very well. We retrieved the catheter and everything went fine. This is also another patient with a whole liver. You can see here the tight stenosis and the benign anastomosis, treated with balloon dilation, and this was the patient left the room with the tube in place, and this was the final collateral 1 month after treatment. This patient did well, and he didn't need any further treatment. So these are very nice results, and you can also say how cool you are. Yeah, we are very cool. However, the statistics exist, and so we are faced frequently with these kind of situations. Tight stenosis, we were able to go through the stenosis. We deployed a tube, then we dilated, it was very well. This is a aerobic, it's not a problem, so the stenosis was very well, and when we did the cholangiogram 2 weeks later, the stenosis was still in place. Another patient, that this was the final cholangiogram after 2 sessions of dilation, so we decided to retrieve the tube. The patient came back 6 months later with this tight stenosis and anastomosis, and again we started with balloon dilation, the biliary drainage, and so on. Another patient with the same situation, you see tight stenosis, you can, here you cannot see passage of the contrast media to the jejunum. So even though we were able to go through the anastomosis with the wire, we dilated, and this was the control after 3 months, after 3 dilation procedures. So why I'm showing you that? Because due to these results and the high recurrence of these anastomotic biliary strictures, and taking into account that these are minimally invasive techniques, and that persistent dilation has been proposed as the key point for success for these issues, we are now thinking to set up a new protocol in order to treat these kind of patients, and we are going to do so with the ELA biodegradable stents. The purpose of this protocol will be to demonstrate the feasibility, safety, and mainly the efficacy of this stent in the treatment of biliary strictures. This will be a prospective study, and we are going to include initially 20 patients in this new study protocol. The inclusion criteria will be all patients in pediatric age, of course, with any anastomotic biliary stricture, and we are going to keep out of this study patients with less than 30 days after surgery. The concept form is already written, and the consent form of the whole study is already approved by our IRB department in our hospital. This is the new for you. So after the deployment, stent deployment, all patients will be followed monthly during the first 6 months, and then at 1 year. And we are going to assess the stent patency, the time to complete dissolution, and mainly the efficacy on the treatment of this recurrent stenosis. And this follow-up will include laboratory tests, ultrasound exams, and in some cases, MRI. Why I'm saying in some cases, because I'm not going to take a patient to the MRI and make an anesthesia for this procedure, so I'm going to include an MRI in this follow-up, just in patient where I won't need anesthesia for this study. So we believe that this could be a very nice option to know if this kind of prosthesis may, this is our hope, to do a sort of revolution in the treatment of this very frequent entity that we found in our pediatric patients. Thank you so much for your attention.
Thank you, Sergio, very much. If you can please stay there, because your presentation is the only one for biliary stent, so we will open the discussion straight away. To anybody having a question or any similar experience? Anybody treating pediatric patients after a liver transplant?
Yes, I'm from Helsinki, Finland. We have exactly the same problems as yours. I think 2 out of 3 pediatric patients have this problem after the split liver transplantation. We have done just like you, dilated them or time and again. And one of the other problems has been that actually we do have technical failures also. And in the resected liver, 2 cases, we have redone surgically the biliary anastomosis, the ruined anastomosis, but the problem wasn't there. It was in the split liver graft, and it seems that during the resection we had a severe one of the intrahepatic ducts. I wonder whether those stents could be like sort of intrahepatic location. Well, we haven't tried it, but that's what has been our problem in 2 cases. This unnecessary operation.
In our experience, the results with intrahepatic lesions are much higher compared with this stomatic structure. And our results are similar to those reported in the literature. So each time that we find intrahepatic lesions, we always try to dilate with these kind of techniques. And the results sometimes are very nice, and sometimes they don't. But it's difficult to compare anastomotic strictures with intrahepatic strictures because the results are completely different. We are happy that the results are different. So sometimes, but another issue is that sometimes you can find, or in your case, thousands of intrahepatic stenosis, so it's difficult to treat each lesion. But the results, as I said before, with intrahepatic lesions is very well compared with anastomotic strictures. And I don't know, I believe that if we are thinking to deploy a stent in an intrahepatic biliary duct, I'm not so sure if it's going to work well. So we insist each time that we are faced to this kind of lesions, we try to dilate with this technique.
Thank you. Congratulations, Sergio. I'm Juan Anton Pacheco from Madrid, pediatric surgeon. And I understand you are beginning with this protocol now, so you have no experience still with Okay, so what's the current experience with this type of stents in other groups, other hospitals?
Yeah.
Are they using them, and what's your...
According to my knowledge, in Argentina there's already one group performing, not in transplant patients, they are deploying the stents in benign biliary stenosis. I'm very close to the person who is leading this study, and the results that this group is getting with this new stent is unbelievable. And that means that this group already presented their preliminary results in the last SILSE meeting. SILSE is the European Society of Interventional Radiology, and this group presented their results in this last meeting a couple of weeks ago in Barcelona. And if this group is able to keep these results, I have no doubt that the treatment of benign stenosis will be completely changed. So this idea of treating these pediatric patients, in this group of patients, these liver transplant patients, started when I met these guys in Argentina, and they showed me what they were doing with benign stenosis. This is a completely different group, you know. These adult patients made this, the lesions that they are treating are mainly post-surgical complications, but the results that they are achieving are unbelievable. So based on that, I have my hopes about the result of our protocol.
Okay, thank you very much. Another very short question. So you asked for the stents as we do in Spain to give to the company. How much time do you need to get the stents in Buenos Aires when you ask for it?
We have the chance that based on the study that this group is already working in Argentina, I don't have to do any paperwork for getting a sort of authorization for our FDA. So the time that we will have these stents in Argentina depends on when Martin decides to send these processes to me.
Okay.
And believe me that this question wasn't prepared. It was just his will to ask this question. Thank you so much for this question.
Thank you.
Thank you very much. It's not only my decision when I it's the manufacturing, but yeah, there are two ways, of course. Either way, we manufacture when you ask for a particular stent for a particular patient, then it takes like 2 weeks to manufacture it here, plus all the way across the ocean. And maybe some travels in customs, which are out of our side. Or if it is a study, like we did with Professor Jimenez, we sent the stents up front because it was a formal protocol study, and all the stents were only for the purpose of use in the clinical study. Then we were able to send the stents up front.
As we discussed earlier.
Yeah.
Any further questions?
Just for interest, we have pediatric transplantations. I don't know how much it's affecting on the biliary anastomosis, but we have found that the arterial anastomosis, when you follow up the transplantation of several months or years, they take all of the occluded later on, and still in some cases the biliary anastomosis work, and in others it does not. Do you have the same kind of experience?
As I showed before, our transplant surgeons work a lot, and we are performing more or less between 900 and 1,000 procedures a year. And 30% of these procedures are related to transplantations. So I can show you, I have my laptop in my room, but I can show you later. We have all pictures, that means stenosis of the IBC, these biliary strictures, intrahepatic biliary strictures, hepatic artery problems, portal vein dilations. I presented last year in the US our series of more than 25 patients with portal vein stenosis and effusion treated with percutaneous techniques. We have all kind of we are faced with all kind of complications, and when a patient is diagnosed with an artery occlusion, we are sure, is absolutely sure that this patient already has or will have in a very near future problems with his biliary tree. So I have a very nice picture that I didn't include here because this presentation was focused on biliary strictures. I have some very nice pictures related to the question that you have mentioned. That is problem with the artery and a completely dilated and irregular and completely diseased biliary tree. So if we are faced with stenosis, artery stenosis, we are always trying to dilate it. And if the artery is occluded, if its occlusion is not so old, we are going to try to recanalize this artery because the prognosis long term is very bad. Thank you. Thank you.
It's not over. We have one question from Paediatric from Belarus. So there will be a little translation here from Russian to Czech, from Czech
I don't
language.
speak Russian, so
Yes. Also from Czech, I guess. So give me a second.
sure.
Okay. The question is about the procedures before stent implantation. The oracle asked if, from your opinion, it is possible to not do any balloon dilation, but go as a first line with the stent.
Primary stent. Why not? That means I believe that in our protocol we will start doing first balloon dilation and then stenting. And this I think it's just in the air, but I think that this we are going to do so in order to I don't know how well the profile of the stent is going to help me crossing the lesion without redilation. So if I want to be sure about the stent will go through the stenosis with no problem, and also when we dilate, there's a sort of mark on the balloon that will say me where is particularly these lesions, and that will also help me to decide where I'm going to deploy the stent. But this is just a secondary technical point. But I think that we are going to deploy this stent after dilation for the reason that I mentioned before, to have a more safe passage of the stent device through the lesion, because some lesions, as you saw, are very tight. So I'm not sure if the whole device will go through this lesion without dilation.
Thank you. It's clear. Let's check if this answer is fine. Okay, the answer is fine. The other question is, what types of guide values are you using for analysis of the stricture?
Next question. Yeah. In cases of this tight stenosis, the only guide wires that will help us to go through these lesions are the hydrophilic guide wires. So these are the same guide wires, or the same hydrophilic guide wires that we use for peripheral endovascular procedures. So we usually do go through these lesions with 0.35 inches hydrophilic guide wires. And then once we are went through this stenosis, we change the wire for a stiffer rod. So the first part of the procedure is performed with a hydrophilic guide wire, and then once we are through this stenosis, we change usually with we change for an implant guide wire. It's different.
Okay, so the first one is the soft one. Yeah, the
Hydrophilic. Not only soft, hydrophilic. We let me to go to this.
Okay.
Discussion.
Coming back to the lesions that I mentioned that if they did balloon dilation, they actually made more trauma. So the restriction by this dilation. So did anything like that happen to you, or is it a question of selection of balloon diameter and the pressure you are using?
We presented last year in the Argentine meeting of radiology our series of treatment of non-vascular complications, including this kind of lesions. And we have more than it's almost 300 balloon dilations in the biliary tree in liver transplant patients. After 300 sessions, we absolutely never had any problem with the ballooning step of the procedure. We have hemorrhage in order to try to get in the biliary tree. We have problems getting out the tube. We have problems with the tube that was removed by the patient, but we never had problems with the dilation. We always try to adapt the size of the balloon according to the size and the weight of the patient. And as I showed in my presentation, we are going to ask and have two kinds of stents. 8mm stent for patients over 15 kilograms, and 6mm stents for patients with less than 15 kilograms. And when we choose a balloon for dilation, we try to also consider this point. So usually patients over than 15 kilograms, we dilate them with 8mm balloons, and patients with less than 15 kilograms, this is not a strict law, we are always adapting each procedure to each patient. But in patients with less than 15 kilograms, we dilate their lesions with 6mm balloons. But we never have problems with dilation. And I agree with the doctor saying that this is a traumatic procedure. Yeah, I know. But the results, some patients did very well with this kind of procedure, and we are following the same protocol that are employed all over the world. So we never had any problem with this particular step of dilation of this kind of stenosis. And in any case, if you have any problem, the solution of this problem, because we can have a tear of the anastomosis, or to generate a biliary leak if you are dilating very hard or very high. the solution of this problem is just to deploy a tube, internal, external, and this will resolve the problem in 15 days. Thank you.
Question about the approach, if it is endoscopy for transhepatic, I think it's transhepatic.
Always 100%, because as I also said before, most of these patients are rugally hepatic cholesterol, so it's almost impossible to get to the anastomosis by endoscopy.
Time is getting low. I will have one last question from my side, and more we can do in the summary later on in the afternoon. Yeah. Do you set the number of dilations before you place the stent? Just what is one or more dilations?
You know, I was discussing this point with the chief of the liver transplantation department, and we decided that we are not going to set up the same protocol that we are using right now. That means one dilation control is not one dilation control. If there's still dilation, one lesion, again dilation. We were discussing that all these patients, once they are in our room and we found this stenosis, we are going to dilate, and in the same session, in the same setting, deploy a stent. So we are not going to go to see if these patients are going well with the dilation. We are going to use the stent in the first setting. And you can also compare these patients with all patients that we already have treated. So we will always have control group. So to answer your question, we are not going to dilate several times and then use the stents. We are going to use the stents for the first time. You have a question?
Do you need some safety procedure after the stent implantation, or this is the most important thing?
Yeah. Yeah. Usually, it's a very nice question. Usually when we perform, for instance, we already treat a patient and we are going to do a control collateral 3 weeks later. If the control is quite fine, as I demonstrated in several cases that everything went well, we do not retrieve the tube at this moment. We always keep this tube for other 48 hours in order to avoid infectological complications. So we do the control, we left in place the tube for 48 hours, and then we retrieve the tube. For the patients where we are thinking that we will use this biodegradable stent, we are going to do something like that. We are going to deploy the stent. We are going to leave in place a small, very small catheter, because we don't know to bother the normal flow through the stent. We are going to keep this tube, these catheters, for at least 48 or 72 hours, and then we are going to retrieve it. It's a nice question.
Okay, thank you very much, Sergio.
Thank you so much.
Now,